Hi, I'm Jennifer Salopek, founding editor of Wing of Zock. I'm here today with Joseph Saseen of the University of Colorado, who was honored recently in the AAMC's Clinical Care Innovations Challenge. Joe, tell me about your innovation.
So our innovation was developing, evaluating, and refining a clinical pharmacy intervention for our family medicine clinics. I was a member of a clinical pharmacy team that was led by Joseph Saseen. So he was the principal investigator and the lead clinical pharmacist, and I was one of his collaborators in helping to establish this overall clinical pharmacy initiative. We decided we had this long-standing relationship with the University of Colorado, the relationship being with clinical pharmacy and the Department of Family Medicine, where we had faculty members who were co-funded and co-appointed between the School of Pharmacy and the Department of Family Medicine. So we had this relationship for a very, very long time. But at the University of Colorado, the clinical pharmacists had pretty much worked exclusively with the residency training clinic and also with the hospital service. But in 2001, we decided to span out and actually go into some of our smaller faculty practices that are part of the University of Colorado, but a distance away from the main campus.
Was there a specific need that was designed to address?
So the overall need was really to sort of infiltrate and sort of incorporate in an interprofessional manner clinical pharmacy along with medicine as far as providing care to patients.
So how do they work together now under this initiative?
So how they work together now is a little different than how it first started. So I'll start off with how it started and sort of transition to how it's working now. So Joe Vandegreen, who is a faculty member at the University of Colorado, co-appointed between the School of Pharmacy and the Department of Family Medicine, actually practices currently 1/2 day a week at each of 2 clinics. But initially in 2001 we started with our first Park Meadows clinic, and he spent 2 half days a week for about 3 to 4 months face-to-face working with the clinicians at that site. That site only had a handful, approximately 5.4 FTEs of physicians, nurse practitioners, and PAs. So it was a smaller practice. So he had that face-to-face time to establish rapport with the medical team there. He provided 2 major services. One was sort of prospectively looking at patients that were being seen in that clinic and identifying needs for clinical pharmacy intervention. And then he also responded and provided services on a consult basis. So after that first 3 to 4 months of face-to-face time, it transitioned at the Park Meadows Clinic to a more remote model, where Joe Vandegreen actually still provided the clinical pharmacy services, but he provided a lot of it remotely through the electronic health record by identifying patients who required clinical pharmacy intervention, by actually facilitating the communication through the electronic health record. He still has a presence there, but he only has to be physically on site probably about 1/2 day a month. The rest is done remotely. After about 1 year, we evaluated that process. We saw that we're able to demonstrate after that 1 year snapshot actually a lot of valuable information. We quantified the types of interactions and the types of documentation that he provided as a clinical pharmacist, the types of opportunities for providing clinical pharmacy recommendations, recommendations that improved quality and actually improved safety, things such as recommending the addition of drug therapy or change in dose in drug therapy, or sometimes actually removing drug therapy to manage a major drug-drug interaction or to remove unnecessary therapy.
So Joe, you mentioned that it was important for Joe to visit in the clinics at first and develop the rapport and the relationships. Why was that important to the success of the initiative?
It's really important for, I guess, a few reasons. One is that those physician groups and the medical groups, they may not be accustomed to working with a clinical pharmacist, so even though we're part of a large university system, some of them may not be familiar with what types of patients or clinical issues can be managed or can be helped out by a clinical pharmacy evaluation. So that face-to-face time helped build rapport and gain trust amongst those physician colleagues, but it really was also an opportunity to educate that medical staff on what a advanced pharmacist, a clinically trained pharmacist, can actually provide to primary care.
Gotcha. So did you have any big challenges you had to overcome to implement this initiative?
There are a lot of challenges when you implement a new clinical program. Some of the typical ones we didn't encounter, maybe because the culture was that these were academic clinics that were used to multiple disciplines. So I think some traditional challenges that we really didn't experience were, territorialism, not wanting to actually give up some care to patients. That we didn't really experience that because it was always a collaborative type of relationship. So I think probably the biggest challenge that Joe had and we had in evaluating this overall program was actually finding time to actually do the remote clinical pharmacy services, to go out there to the remote sites. And it's a challenge that's easily overcome. You just have to actually plan ahead. And I think when you're doing these kind of remote services coupled with face-to-face time, because right now, Joe Vandegreen does still spend some on-site time at these clinics. It's just that 1/2 day a week is that, and maybe 3 other half days per month are done remotely. So I think the success there is really budgeting the time and not just trying to throw in a couple half-hour slots, but to really block off your time and devote it to those clinical initiatives.
Sure. So how are you measuring the success of the initiative?
So for the first year, we measured success. We did a whole evaluation of that one clinic, the Park Meadows Clinic that came online in 2011, and we looked through all the patients that were evaluated. And of the patients that were evaluated, and part of the evaluation is that when a patient needs some type of recommendation or outreach by the clinical pharmacist, a formal note is documented in our electronic health record. The way we evaluated that success was to summarize how many patients actually received a full comprehensive medication review and how many recommendations were made, what types of recommendations were provided, and most importantly, how many were accepted. And our definition of acceptance wasn't just verbal agreement by the providers that they agreed with the recommendation, but actually was implementation. Because we often find that sometimes recommendations are received well, but they're not always implemented in the patient level. So we went to that step of defining acceptance as implementation. And we overall had 315 overall recommendations that were provided from approximately 128 patients. So the average patient that had a full evaluation had more than one recommendation in their consult notation. We had a high acceptance rate of 70%. And again, our acceptance rate was implementation of the recommendation, not just agreement with it.
Right. What do you think is the most innovative thing about this project?
That's actually the key to this one, is what is innovative, because it's not innovative coupling pharmacy with medicine. That's been done for years, and it's not even novel that it's done remotely offsite. Actually, let me rephrase that. The novel part is that it's done remotely. It's not novel that clinical pharmacy works with physicians and other medical providers in outlying clinics. So the innovative part is actually implementing the remote part of this service and using the electronic health record to its fullest. I think without that electronic health record being so robust and allowing for identification of patients that need clinical pharmacy evaluation and a way to systematically and sort of in an organized manner put forward those recommendations, I think that's an innovative component. We've actually phased in another clinic in 2013. We've moved into the Boulder Clinic. But prior to that, we had to change our structure a little bit because this is where the refinement of our service came in. I think we found out real clearly that just doing a scan of patients that are coming in to be seen over a week's period of time and looking for those who have multiple medications or have certain chronic diseases that are uncontrolled, that was actually pretty laborsome. So the refinement was actually implementing a priority index score. We call it the CP2 score. And it runs in the background of our EPIC, which is our electronic health record. And it assigns a score to each patient that's being seen the following week. And the score is derived, we're actually in the process of validating this score right now. It's derived by looking at patient characteristics such as diseases from ICD-9 codes, number of medications, types of medications, and then some specific values such as lab values or vital signs that are abnormal. And based on our CP2 overall equation, it gives us a score. And patients with higher scores are more likely to actually require a recommendation from a clinical pharmacist. We've done that through an evaluation of 1,100 patients at the Boulder Clinic and actually looked at how many would require a clinical pharmacy intervention so to help refine our score. So we're in the process of validating right now because I think that in addition to innovation from just having remote service, having a way to prioritize patients so that you can be efficient with your time is sort of hopefully our secret for continued success.